Hello and good afternoon. I'm Mary Beth Marsden, and welcome today to GBMC's Ask the Expert, where we focus specifically on issues surrounding oncology and various cancers. And this month happens to be Cervical Cancer Awareness Month, so it's very appropriate that we welcome today to join us Dr. Kim Levinson, who is the Director of Johns Hopkins Gynecologic Oncology at GBMC. Dr. Levinson, thank you so much for being with us today.
Thank you for having me. I'm happy to be here.
Let's just take the broad view real quick and just tell people what gynecologic oncology really encompasses.
Yeah, so gynecologic oncology is basically a specialty that focuses specifically on GYN cancers. So the most common ones that people tend to think of are ovarian cancer, cervical cancer, uterine cancer, and also includes vulvar or vaginal cancers. So we as gynecologic oncologists actually do the surgeries for these types of cancers, but we also are fortunate enough to follow our patients kind of throughout their course and help them with either chemotherapy if that's what they require, or all the way into surveillance. So we really do follow our patients the whole way through and not only perform their surgeries, but also treat them subsequently as needed.
So, Dr. Levinson, throughout the course of the next half hour, we're going to talk with you specifically about many gynecologic cancers, but specifically cervical cancer. But before we do that, I think it's also important to note that everyone who is maybe having some kind of symptom they're concerned about, or they're currently in treatment, or they have been in treatment, are doing so and taking care of themselves under the umbrella of COVID-19. And we're all dealing with that. So,
Yeah.
can you talk about how, or the message you want to get across to people about how COVID-19 is possibly affecting their treatment, possibly affecting when they can come see you, just kind of has created a different atmosphere when it comes to gynecologic cancers?
Yeah, I think that's a great question. I think that's one that a lot of people are wondering about now. And I think, especially initially when the pandemic started, there was a lot of fear about going to the doctor. And, our concern as physicians was, is that going to delay diagnosis and treatment of in my situation, cancers, so that we're seeing people when cancers have progressed to later stages and are less curable. And I think the main thing that I want patients to know is that we are here for patients. We are seeing patients. We are taking appropriate precautions and safety measures to make sure that our patients are safe. And there's a lot of different ways that we're doing that. So certainly, we are doing telehealth, and I do a lot of consultations over the phone and make sure that we can make the appropriate recommendations for patients and help to triage which specific issues are ones that need to be addressed versus those that might be able to hold off on. And then, of course, we are seeing patients in the office when necessary. And so, if something needs to be evaluated, we have absolutely taken every safety precaution to make sure that when the patients do need to come into the office or in to get chemo or in for surgery, that every precaution is taken to maintain patient safety. And so, of course, that includes cleaning and mask wearing and all of those things that we've all heard about, maintaining distance, and then really making sure that patients are tested appropriately before surgery, for example, and really just that every precaution is taken to keep people safe.
What is right now, these days, in this area, the most common gynecologic cancer?
Yeah, so uterine cancer is the most common gynecologic cancer. Uterine cancer, the most common type of uterine cancer is endometrial cancer. So it's a cancer that starts in the endometrial lining, which is the lining that builds up and sheds every month during a period. And that is the most common type of cancer that we treat. The good thing about uterine cancer, or endometrial cancer in particular, is that we often are able to find endometrial cancer early, meaning that we can find it at an early stage. And that's because uterine cancer often presents with a symptom of bleeding. And in a postmenopausal woman, any episode of bleeding would be something to be investigated. And even in premenopausal women, if there's abnormal bleeding or what we call intermenstrual bleeding or bleeding between periods, that many times does deserve further workup as well to make sure that there is not a cancer or a precancer there. So, the thing about endometrial cancers is that endometrial cancers are associated with obesity. And so as we see kind of the obesity epidemic rising, we similarly see an increase in the rates of endometrial cancer. And that's mostly because the extra tissue kind of that people get around the middle does produce estrogens, and then you get this imbalance in the hormones there that can cause stimulation of the uterine lining, and those abnormal cells can then go on to form a cancer there.
So where does cervical cancer sort of fall into the list?
Yeah, so the cervix is the opening of the uterus, and this is a cancer that originates in that opening of the uterus. So fortunately, over the past 50 years or so, we've done a much better job at detecting cervical cancer and finding it early or even in the precancerous stages. And that's because of our screening strategies, which we'll talk more about. And then, with the more widespread vaccination, with the HPV vaccination, we've further been able to decrease the risks of cervical cancer through that.
Okay, so let's talk about HPV. And I think that even though it's been in the media for many years now, particularly in light of the vaccine, is all cervical cancer caused by HPV?
Yeah, so the easy answer is yes. About over 99% of cervical cancers do have HPV. And so, if we're getting very detailed, there are specific, very rare subtypes of what we call cervical cancers that may not be HPV related, but by and large, really cervical cancer is HPV related. Again, this is a cancer that starts in the uterine cervix, so the opening of the uterus. And there's really two predominant subtypes of cervical cancer, one which is called squamous cell cancer, and that makes up about 70% of cervical cancers. And then the other predominant subtype is called adenocarcinoma of the cervix, and that makes up about 20 to 25% of cases. So you do have these very rare subtypes which may not be HPV related, but again, very rare to find those.
So we keep using HPV, and that is the common way to talk about it, but it's really called the human papilloma virus, right?
Correct. That is correct.
And with the vaccine, which is available starting when teenagers
so actually younger than teenagers.
Oh, really?
Ideally, we want patients to be vaccinated when they're between 11 and 12, and it can be as early as 9 years old. And the reason for that is because really this is a preventive vaccine, meaning that if human papillomavirus is already, if a patient already has HPV, then it's not going to cure it. Okay, so we really need to give the vaccine before somebody has been exposed to the HPV virus. And of course, the major form of exposure is intercourse. And so really, we're trying to vaccinate patients before first intercourse, and ideally around the age of 11 or 12, but as early as 9 years old.
And this is a double vaccine?
So yes. If a patient gets it before the age of 15, then 2 doses are required. If it's after the age of 15, then 3 doses are required.
Which is a relatively new vaccine. I mean, it's been around for a number of years, but as vaccines go, it's one of the newer ones, right?
Well, I guess it's all perspective, right? I mean, yes, I guess.
The COVID vaccine will be the newest. But.
Right. That's absolutely true. I mean, certainly, we have a lot of childhood vaccinations that many people are potentially more accustomed to. I think now, given the many years of safety data and efficacy for this vaccine, the hope is that people are becoming more familiar with this vaccine and more comfortable with it as well.
Is it your belief that if all children get vaccinated, that we could, in some ways, get rid of cervical cancer?
Yes. Yeah.
That's pretty powerful.
Yeah. So, the non-valent vaccine, which means, 9 virus strains, essentially, covers 9 virus strains. And so, we know that there's over 200 HPV virus strains. However, the vast majority of cervical cancers are really caused by two HPV virus strains, and those are called HPV 16 and HPV 18. And those are really, the most concerning strains of the virus in terms of their ability to go on and form cancers. And so, even when we had the quadrivalent vaccine covering 4 strains, that was largely effective at preventing most cervical cancers. And now we have the nonavalent vaccine, which really covers, in studies, basically 97 to 100% effective.
So I'm gathering that the reason really to have even Cervical Cancer Awareness Month is because the word isn't completely getting out about the vaccines, or people aren't completely buying into it. Is that accurate?
Yeah, I mean, from my perspective, and just to be 100% honest with you, it's somewhat of a biased perspective, right? Because I see this population of patients. But by and large, the women who are affected by this disease are relatively young women. And unfortunately, we still see this disease killing young women. And, from my standpoint, since we have the HPV vaccine and we have good screening mechanisms, so good primary and secondary prevention mechanisms, this disease should be preventable. And the fact that this is still killing young women is just, unacceptable from my standpoint.
What is the difference between cervical cancer and dysplasia?
Yeah, so dysplasia is actually a precancer. So it's basically abnormal cells in the area of the cervix, but they haven't made the transition to become a cancer, meaning that they don't have the ability to invade other tissues. So that's the whole point of preventive screening practices, which is to identify these abnormal cells when they are a dysplasia. And at that level of a high-grade dysplasia, meaning that they haven't yet made that transition into a cancer. And if we can identify those cells when they've become abnormal due to an HPV virus infection, but they haven't yet made that transition, then we really can prevent cervical cancer. We can remove those cells and ensure that they don't go on to form a cancer.
Sort of like getting rid of a precancerous skin lesion.
Yes, that's exactly right. So this obviously is in a different area, but same idea. You have some cells in that area that are abnormal, and if we remove those, then they don't have the ability to go on and cause a malignancy.
And if you get the vaccine, does that also prevent the dysplasia?
So yes, so it prevents the HPV virus overall. And so yes, you would prevent any subsequent cellular abnormalities related to the HPV virus because you're preventing the virus overall. So I think the easiest way maybe to think about it is, I kind of describe HPV as the common cold of sexually transmitted diseases, meaning that for patients who are sexually active, just about everybody gets it if you haven't been vaccinated. But most people will clear the virus on their own. So the immune system acts to kind of prevent or clear the virus once it's been contracted. But unfortunately, just like the common cold occasionally, which can kind of go on to cause a pneumonia, same thing with an HPV virus. It can kind of sit there and persist in those tissues and then go on to cause changes in those cervical tissues. So you can kind of almost think of it like a stepwise fashion. So somebody contracts the HPV virus and, maybe it causes some changes in the cervical cells there, but then maybe the body kind of, fights against it and those cells, become, reverse essentially. But then you can see progression of disease too. So you can see persistence of disease, you can see regression of disease, or you can see progression of disease. And as the HPV virus causes more abnormalities to the cells in the cervix and they become more in this area of a high-grade dysplasia, then the likelihood of those cells going on to become more abnormal and form a cancer becomes higher. So really we're looking for this abnormality of this high-grade dysplasia when we do cervical cancer screening to make sure that we can get that taken care of before it goes on to cause a cancer.
If you've been vaccinated, do you still need to be screened?
You do, as of right now, and that's because, for many, many reasons. But essentially, even with the vaccine, there's no way for us to 100% determine that somebody has not contracted an HPV virus prior to vaccination. And realistically, because, screening can help to pick up any abnormalities there in the cervix, even that may have developed previous to a vaccine, we are still recommending that everybody be screened.
And this is a pap smear?
This is a pap smear and an HPV test. So there's several different types of cervical cancer screening that we have and different recommendations by different organizations. The most recent recommendation by the American Cancer Society is for what's called primary HPV screening, meaning you're just looking for the HPV virus alone. What we've classically done, or more recently, I should say, is what we call a co-test, which means that you're tested both for the HPV virus and with a pap smear, which actually looks at the cells under the microscope to determine if any of those cells are abnormal. And many practices are still using both of those tests, the HPV test and the pap smear test, to help guide and direct what needs to be done for patients who may have changes there.
And is there a certain age at which a woman no longer needs to have that test?
So that's a very good question and a very interesting one. So it's partially based on a patient's history. And, recommendations for screening have only become more complicated. And so I think that it's very important that each individual patient really have a good conversation with their practitioner to determine their own individual risks. Our screening guidelines have more recently transitioned to a risk-based assessment, meaning that for each individual patient, we look at their history of their screening and try and determine exactly what their risk of a high-grade dysplasia and or a subsequent cancer would be based on their prior screening. And then that's really what guides decision-making as for what they need. Now, classically, what has been kind of the guidelines is that if a patient is over the age of 65 and has not had any abnormal screening for over 20 years, then that patient can exit screening at that time. However, I will say my own personal opinion is that, we know that their cervical cancer does still develop in women age 65 and over. And so it's very important to understand each individual's risk factors and not get into this mentality of, you're greater than 65, you don't need it, because there really are patients who are higher risk who should continue with screening.
I thank you for telling us that, because I think women get so many mixed messages. It's really hard to know what to do.
Agreed. And I think that that's important from the standpoint of women who've had a hysterectomy as well. Again, this kind of box thinking of, I don't have a cervix anymore, I don't need screening anymore. But actually, that's not true. If a woman has a history of a high-grade dysplasia in the past, we still do need to be checking that HPV virus isn't affecting the cells of the vagina, because HPV can affect the cells of the vagina or vulva as well.
And I'm wondering too, do you see that women have to jump through hoops to get that testing to get it covered by insurance? Or is that
no,
not an issue?
Yeah, it shouldn't be an issue. I mean, every insurance company's coverage is different, but I will say, we usually do not have issues getting that covered if there is a history of dysplasia.
All right, over 65, don't give up on yourself.
That's right. 65 is the new 55, right?
Exactly. So we have so many questions too that were written for you specifically, and for this conversation, I want to get those in because those people are probably watching right now. And so I'm just going to kind of go down some of the list, and most of them do have to do with cervical cancer or dysplasia. So the first question is, and I think we touched on this a little bit, but how likely is a recurrence of cervical dysplasia after 2 LEAP procedures? And of course, we would need you to explain what a LEAP procedure is. And there's a second part of this question as well. Do they affect a woman's ability to bear children and to carry children?
Yeah, so this is a long and kind of extended question, and I'll try and kind of be as concise as I can about it. So a LEAP procedure is the procedure that I'm talking about, where we remove those cells of the cervix. There's actually 2 different procedures which kind of do the same thing. They can either be called a LEAP or a cold knife conization, and that's just kind of the strategy that we use or the technique that we use to remove those cells of the cervix. And so, when we do that, the goal is to remove that area of abnormal cells. And of course, we know that we don't necessarily cure HPV because there's really no cure for HPV once it has been contracted. However, if we can remove the abnormal cells that we think, affect this area, then that really does decrease the risk of a recurrence or persistence of that disease and progression to cancer. In terms of, what is the recurrence rate, it really depends on a lot of different things. What I will say is that, my team recently did what we call a meta-analysis, meaning that we've looked at all the data that's out there, specifically with regards to patients undergoing LEAP or cone for cervical dysplasia. And one of the things that has been looked at is whether the addition of the HPV vaccine in that setting can decrease the risk of a recurrence. And what we found is that it does, actually. So for patients who have not been vaccinated yet, and have a high-grade dysplasia and are undergoing a procedure to remove those abnormal cells, if they get the HPV vaccine at the time of their excision, meaning in and around the time of their excision, doesn't have to be right when the patient's on the operating room table, but that actually helps reduce the risk of recurrence from about 6% to about 2%. There's many different factors which have to do with recurrence rate, not only the addition of the HPV vaccine, but things such as whether the margins of the excision are positive, meaning do we see that the whole area was circumscribed without any dysplasia at the edge of the resection, okay? So that plays a big role in recurrence rates. Also, the type of HPV virus strain. So we know that HPV 16 is kind of the most virulent strain, and that patients with that type of HPV have a higher risk of recurrence as well. The size of the lesion plays a role, and whether there's glandular involvement plays a role. So there's all these different factors. And then when you're talking about one LEAP versus two LEAPs, it doesn't necessarily depend on number as much as it depends kind of on what was removed, how it was removed, how big the lesion was that was removed, kind of all of those different factors. So, overall, I would say, with negative margins, a patient probably has a recurrence rate less than 5% or so. With positive margins, it's probably higher to around 20% or so. But all these other factors also play a role.
And while we're talking about women of childbearing age, we just got a question in right now that seems to be sort of along the same lines. Could you discuss fertility preservation with women of childbearing age with uterine cancer?
Yeah, absolutely. I just want to touch on one other thing about the cervical cancer, which was about pregnancy. I think the other question was about the pregnancy, and I just want to answer that really quickly, of whether patients can become pregnant after LEAPs. And they can. There are some increased risks after LEAPs, and the primary ones, patients can get cervical stenosis, meaning it's harder to dilate the cervix during childbirth. There's also some increased risk of a second trimester loss, but that goes from less than 1% to between 1% and 2%, so still not super high. It's not a very high risk of pregnancy loss, but it is higher than the baseline. And so those kinds of things are just important to discuss, but certainly, the goal here is to preserve fertility, and most women are able to go on and carry a pregnancy.
Okay, and I just want to interrupt with a dumb question. I had heard a story, I forget when, about a woman, or maybe women believe this to be true, that when they gave birth vaginally, they could slough off cancer cells.
Well, so, how or why or mechanistically exactly what happens, that's kind of a little bit of a different question, but we do see some regression of lesions with childbirth, with vaginal childbirth. And so, whether that has to do with the healing and the immune cells that kind of are, going specifically to that area and how that affects healing of the cervix after childbirth. But certainly there can be regression of lesions after childbirth.
Okay.
So back to the uterine question. Cancer. I'm sorry.
Yeah. No, I'm sorry.
No, it's fine. So with uterine cancers, this becomes a little bit more challenging, obviously, because, a cancer that starts in the womb where, a fetus would grow, it can be a little bit more challenging to treat in a, way that conserves fertility. That being said, if there are early cancers, meaning that we can tell that there's not significant invasion into the uterine wall, and cancers that are what we call low grade, and grade basically means how aggressive the cell type is. So when we look under the microscope and we see the cell type, how aggressive is that cell type? And so for cancers that are low grade and what we call clinically early stage, meaning that they're either confined to the endometrial lining and have not invaded the muscular wall of the uterus, or even if they've invaded just a little bit of the uterine wall, those we can treat with hormonal therapies. The most common way that I like to treat those is with a progesterone secreting IUD, meaning that we put in, an intrauterine device that, a lot of people use for pregnancy prevention, but, that has progesterone in it, which can basically treat the cancer in the uterine lining. And so, it doesn't work for every patient, and monitoring is important in those patients to make sure that there's no progression of disease while on those types of therapies. But certainly we can treat women in that way, and we've had many patients who, fortunately, we've been able to have the cancer regress and go on to carry pregnancies.
That's great. A couple more questions. I want to get as many of these in as possible. What is CLL, and does that increase my chance of having gynecological cancer?
Yeah, so CLL is actually a type of lymphoma. It's a blood-related cancer, and it does not increase the risk of a gynecologic cancer.
And then this is a very specific question, but I think you can look at it in broader terms as well. Someone is talking about the COVID vaccine, and this particular individual is 74 years old, had ovarian cancer, had chemotherapy, wanted to know if they should be, I think her age does make her eligible, but should they be eligible to receive the vaccine before the general population? But then really just to ask again, is it good to get the vaccine if you're undergoing treatment or you have had these cancers or your immune system is compromised?
Yeah, so, I am recommending the COVID vaccine to my patients. And I do think that, it is a really important thing that we can do to keep patients healthy right now. In terms of kind of the, phases of the vaccination procedures, according to our state, and it is different in every state, this particular patient would be in the 1C group. And so, there are medical comorbidities which can kind of change the group of each person. And, all of this information is constantly updated on, the Maryland Health website. And you can see kind of which group you are in and when you might be able to be vaccinated or be eligible for vaccination. And certainly, as we hear more, at our practice and when things are being made available to different patients in different phases of vaccination protocol, we're doing all we can to help keep patients abreast of the information.
Great. Another question, very specific. I have been treated 3 times in a month for odor, burning, and pain when I urinate. My doctor says it must be from the cancer treatment. Is a urologist the correct physician to see for this particular issue?
Yeah, so a urologist certainly is a good person to see. I think the other recommendation that I would make is a urogynecologist, so somebody who focuses that specialty is a gynecologist who focuses specifically on urologic issues and gynecology. So those physicians also can really help in further investigating whether there's any issue from a urinary or vaginal standpoint.
Another patient wrote in and said that she has advanced or has had advanced ovarian cancer, has had 2 lines of chemotherapy. This particular person has read that rucaparib or Clovis, you'll have to,
Yeah.
is that correct?
Rucaparib, yeah.
It is reported to have a prolonged period without disease worsening. What is this and what are you finding?
Yeah, so rucaparib is one of the PARP inhibitors. And PARP inhibitors are, one of the greatest steps that we have taken in ovarian cancer treatment. their utility has really been tremendous in our ability to treat ovarian cancer patients and improve outcomes for patients. However, their use and their utility does have some dependence on some various factors that are individualized to each patient. So specifically, we really are looking for different genetic mutations in the patient's tumor that make them more or less, that make PARP inhibitors more or less efficacious for patients. So we know that PARP inhibitors work extraordinarily well as a maintenance therapy for patients, for example, with a BRCA mutation. And a BRCA mutation is basically a mutation, a genetic mutation that makes patients susceptible to breast and ovarian cancers. And patients who have that mutation really using PARP inhibitors in the maintenance setting, meaning after they've undergone surgery and primary chemotherapy, using that as a maintenance to kind of maintain their disease-free state really has incredibly improved our ability to prolong that time period to recurrence and hopefully keep that going long term. Whether or not that means a cure, we're still looking at data. But, I think that this has been an extraordinarily promising new treatment that really improves patients' outcomes. Now, it's not just BRCA patients who benefit from PARP inhibitors, and we do use PARP inhibitors in the maintenance setting for patients with and without BRCA mutations. And certainly there is some prolongation of what we call disease-free survival, which basically means the time between treating a patient's cancer and the time that that cancer might recur. So we get a prolongation in that time with the use of PARP inhibitors in the maintenance setting. However, the degree to which that occurs really depends on several different changes within the tumor and different genetic changes that we look for.
So much to discuss, but I want to sort of wrap up our conversation and just kind of circle back around to just everything that GBMC provides to a patient, just sort of sum up what the oncology program means to you and really what it would mean to the people who are your patients.
Yeah. So, one of my greatest joys in being able to treat patients here and kind of through our program is really the best evidence-based medicine that we have, combined with a really personalized approach to care of the entire patient, meaning that we understand that just as important as it is to understand how patients get the best outcomes and what treatments provide the best survival benefits and all of those factors which are so important in patients' outcomes, just as important as that is, it is as important to recognize that patients go through a lot when they are diagnosed with a cancer. And there's all these other factors that play a huge role in how patients do and how they manage their disease and how they deal and cope with their disease. And our goal really is to treat the whole patient in that regard and to really focus on all those elements, not only to get them the best treatments and the best outcomes, but also to give them the best experience personally and help them through their diagnosis and treatment through every step of the way. And so I think that's what we're really focused on here at GBMC and what we're, trying to do with the cancer program and specifically in our Gynecologic Oncology division as well.
Dr. Kimberly Levinson, such a pleasure to talk with you today, and thank you for everything you do on a regular basis, but particularly now during COVID. Just really thank you for being there, and thank you for keeping the treatments going and the awareness going, and it was great having this conversation with you.
Well, I really thank you for the opportunity to be able to talk to everyone and be able to help disseminate this information, which I think is so important for women to know and understand. Thank you so much.
Thank you. Take good care.
You too.
And thank you for joining us.